Hello, and welcome to another episode of No Notes, where the conversation is always a perfect 10 out of 10. This podcast is powered by Eleos, the most used and most loved AI platform in behavioral health, equipping more than 130 organizations and tens of thousands of providers with powerful automation tools that streamline documentation, simplify compliance, and surface deep care insights that drive better client outcomes. I'm your host, Dr. Denny Morrison, and for today's episode, we're excited to be joined by my old friend, Dr. Wes Williams, the CIO of WellPower, formerly Mental Health Center of Denver. We'll chat about Wes's journey from direct care provider to IT leader and explore the many ways AI is shaping the rapid evolution of care and unlock unprecedented opportunities for innovation. So, welcome, Wes, and thank you so much for being here.
Yeah, Danny, thanks for having me. It's an honor.
You bet. So, Wes, you work at WellPower, formerly Mental Health Center of Denver. Tell me, what is that organization about? What do you guys do?
Yeah, WellPower is Denver's behavioral health provider, right? We are a private, not-for-profit organization focused on a lot of folks served within the safety net. We serve at any given time about 10,000 folks across 32 locations. So we provide psychiatry, and psychotherapy, but also, as I mentioned, case management services, psychosocial rehab aimed at sort of health related social needs, getting people back engaged in their education or employment, right? A lot of housing services. So we're the state's largest residential treatment provider with 11 group homes. We strongly believe in sort of the power of housing first in terms of recovery. Right? We also operate a number of crisis facilities, and we are really closely work with the Denver Department of Public Safety in a number of criminal justice involved programs.
I love those kind of programs that are atypical from a traditional mental health care, but they make so big a difference. That's very interesting. So, y- you and I go back a ways and have some parallel histories of being recovering clinicians. Um, so, tell us a little bit about your background, Wes.
I live in Colorado, and I moved here 3 decades ago to go to grad school at the University of Colorado Boulder. I studied child clinical psychology, right? And initially started my career in community mental health as a clinician, right? Doing child and family practice. I did that work for, I don't know, maybe 5 years before shifting into health IT. As I was learning to do clinical work, I struggled with documentation, right? And by struggle, I mean, I got into some serious trouble, like by falling really behind on my documentation, right? But that also prompted me to start fiddling around with different systems, right? So before I moved into health IT, I was still sort of thinking about how can this be easier? Two things about sort of my personal sort of career journey here would be one, in grad school, I was studying child trauma. Right. Really interesting problems, complicated systems like how child development and trauma interact. I think in practice, treating people who are victims of child trauma is much harder, right? And I just am not emotionally cut out for that kind of work over the long haul, right? And I think I was, I don't know, 4 or 5 years into doing this work and started having kids of my own and was experiencing some burnout, right? And at that time, I think we had some opportunity emerge, right? Like the HIPAA security rule went into effect in 2003. And with that, I think most of the community mental health centers, at least here in Colorado, switched billing systems to become compliant, right? And with that, purchased without really much of a plan, their first electronic medical records. So, because I had been doing this thinking around documentation and how to help myself from not struggling too much, because there was this unconfigured electronic medical record that we had purchased, right? It created this opportunity, and so I joined first sort of a clinical advisory committee, but then at some point I was like, you know what? I think I could do this. I think I could help configure this myself, right? I came back from an initial sort of conference learning more about it and remember pitching it to the executive director at the community mental health center in Boulder at the time. And yeah, she was like, great, you can have this job. You just remember, you can't keep the pay raise if you go back to clinical work.
Yeah, it's interesting. You and I've known each other for a long time, but I didn't know some of those details. But our backgrounds are very similar. I was the same way about charting. The big difference was I never got caught, but um, but I was terrible at it. I mean, I was just absolutely terrible at it. So when you made that decision to go from clinical care to IT, did you still keep your finger in clinical work? Did you still see clients, or was it a clean break?
I it was almost a clean break. I kept a caseload for 6 months, and then I was like, it was too different, right? Like, part of the challenge was for me at the time, and remember, I was already burned out a little bit, right? But, I was used to carrying a full caseload. Like, there's something about a full clinical caseload that allows you, I think, to let go. You see someone, they come in with some complicated problems. Hopefully, most of the time you're helpful. Like, definitely, you're not always helpful all the time. Like, they walk out of your office, someone else walks in. You focus on them, right? Like, there's sort of a discipline to, like, I'm here in the moment, but then I also let it go, right? And I think to be a good clinician, you need to be able to do that. It's been almost 20 years since I've done any clinical practice, but actually, I'm dusting dusting my license off. This spring, I made a decision to reactivate my NPI number, get re-credentialed with, Medicaid and other payers, and I'm gonna start doing some intakes. It is very different from when I did clinical work, right? When I did clinical work, the only reason I really needed electricity was to make sure that you could see in my office, right? Now, we have these at our big outpatient facility, we've got 4 floors and there's, different front desks, and if the systems go down, like, it's sort of chaos 'cause people don't know where to direct folks, and, like, we're very, very dependent on technology to do our work.
I think it's a ambitious goal, and I am. When you told me you were doing this, I was a little worried that you're going to start carrying caseloads, which not there's anything wrong with that. It's just that it's hard to manage two lives when you're wearing both of
Yeah.
those hats. Your intakes are prescribed blocks of time. And they're pretty easier. There's a lot easier to schedule because that was the reason I ended up not being a player coach because I just I would have invariably I would have a client scheduled and somebody would call a meeting and now I got a conflict and I got to pick
Yeah.
one of these things and both are important. So
Yeah, I'm thinking about, like, what are the different areas of clinical work that I can sort of dip my toe into, right? Intakes is sort of the first one. I'm also curious about our crisis system, and what those sort of contacts, look like. It's a little longer sort of commitment, but only in a single day, right? Like, and so again, like, how do you pop your head in there, and what are the other sort of touch points I can take a look at, but still sort of keep my executive hat on for the rest of the week?
yeah, yeah. Well, at some point I'd love to talk to you offline about how to redo that intake because I'm in full agreement with you about that. That is just one of our major pain points. And most of it is externally imposed requirements that we oftentimes don't have control over, but it has huge effects downstream on all kinds of things. So, um, for example, I mean, I think you're in a position where you might look at that single session therapy literature because sometimes the people we see really only need or want one session. I think data shows about 20% of people we see, and identifying those folks and just saying, yeah, okay, this is all you need, and that's fine. We're call us if you need us, that kind of thing. But we don't do that very much in this industry. It's always let me set up an intake appointment with a therapist, and now you've got people committed on both sides, and it just becomes kind of challenging. So,
Yeah. So at one point, I was doing I had an initiative called Information Systems in Real Life. Like, and so I was doing sort of laps around our organization, right? Would meet with a different clinical team every month. But in one of the sessions, I remember talking with a school-based clinician, and he was describing like what it's like to work with traumatized kids in an electronic health record. And it stuck with me. And what he said was like, look, I know in order to document this session, there are 8 things I need to do. I know that. And I know that like you do them number 1, then number 2, all the way through sequentially to number 8. And if you do it in that order, it works every time. But like when I'm focused on what's going on in the session, it's just hard to keep it straight, and like I get mixed up and I click the wrong button in the wrong order. And then it's like distracting. And so that stuck with me, right? This notion that like, yeah, it is simple. It is simple and you can train people to do it, but you have to also sort of practice it and think about doing it under stress where it is not the first thing that they're focused on.
But do you think AI can help things like that?
Absolutely. I mean, I think, this ambient listening and more broadly generative AI has been sort of an amazing development for clinical work. And, the two things are first, telehealth, right? Like before the pandemic, we were doing like 1 or 2 telehealth sessions a day at WellPower, where we see 10,000 people at a time, right? Like we have 10,000 people open to us. It comes out to like 2,000 appointments a week. So like 400 appointments a day, right? 400 appointments a day. We were doing 1 or 2 telehealth. And the 398 of them were in person. That has shifted now. And so we do a lot of treatment that is not telehealth friendly. We have residential treatment, psychosocial rehab, stuff, intensive community case management, stuff like that, where it's going to be in person. But for our outpatient services, 60% of them are telehealth to this day, right? And that's with people having the choice about that. And, I think we first started using ambient listening with telehealth, but actually now have shifted it, with microphones in the room to sort of the bulk of our outpatient sessions. And it makes me wonder, like, would I have continued to do clinical work if I had this tool, one more thing to sort of shift focus from? It allows clinicians, I think, to really focus on the session at hand. The surprising thing has been like the ambient listening part is not actually the important part. Like, that's what surprised me the most. We did a pilot with ambient listening with Eleos for and the pilot was maybe 5 months, I think. And then last April, so 13 months ago, rolled out sort of a full-scale implementation. People had different ways of doing things, and we have some clinicians who didn't wanna use the ambient listening for whatever reason, right? Like, and, they're using this sort of quick note functionality of leveraging the generative AI to help them more rapidly write the note. In general, I think clinicians took 10 minutes to write notes pre-Eleos, like, or non-Eleos users right now, right? Like, but what we were seeing is the ambient listening folks were, cut it down to about 4.5 minutes. And, the shortcut users, the or QuickNote or whatever, the ones who are using the generative AI after the session, they were initially like their note times were like 6 minutes, still a savings, but not as much. But actually, after a year, they've passed them, and the QuickNote users are getting their notes done at like a minute faster than the ambient listening ones, like down to 3.5 minutes. I talked to one of those therapists and she was like, thank you for finding a solution that like really works for us. Like, and she's 100% on the quick note side, but like really feels like it's made a big difference, and I think we're seeing in terms of outcomes and results, like what we're seeing is, clinicians take all this time. If you think about 6 or 7 minutes per session, clinicians doing somewhere between 20 and 30 sessions a week, it adds up. But it's like 2 or 3 hours a week is what it is, right? Like, one of the beautiful things about this has been without us emphasizing this, because I wondered at the beginning, like, what are people going to do with this time? They could use it to scroll Instagram, but they could also use it to not have their work life creep into their home life, right? And I know we had clinicians who were coming to work, doing sessions, going home, feeding their kids, putting the kids to bed, logging back on to finish their documentation. And that is no way to prevent burnout, right? Like, and so getting it to the point where you can constrain work to work hours is I think, a really important goal. But we've also seen that folks are using this time to schedule more appointments. Like, and that's been awesome. And they've also been using this time and taking this tool and taking some sessions that they were not documenting as billable services because, like, for something short, sometimes you think to yourself, like, it's not worth the extra effort to make this a billable thing. I'm just going to put a quick note in the chart. You give them a tool to make that quick note a little faster, and they start documenting it, like, so that we capture the value we're creating when we're doing these things like targeted case management, where, like, we have a 10-minute phone call helping someone get housing, right? And I think we knew we weren't always getting paid for that kind of work. And, like, tool like this just sort of lowers the threshold of the amount of work it takes to document it appropriately. And we're seeing, and we're seeing good returns there.
Pretty fascinating to me. I mean, and um, I'm pleased because I infer from what you said that the WellPower did not take the position that when you show these improvements in productivity, we're going to give you more expectations of productivity, which is counter to the whole work-life balance idea. But what you said happened with your clinicians is exactly what we've heard in other organizations that did not do that. Eventually, the clinicians start saying, "Hey, I've got the time. I'm willing to help, and I will step up and do these things." And it's there's I think it's worth it. I mean, I'm really happy to hear
Yeah.
that you're those
Our
results.
our clinicians want to do the work. Like, they want to help people. Like, that is, I think when we've had reluctance to, I don't know, add someone more to your caseload, it's partly because, like, it's not just the seeing them that's part of the problem. You've got all
That's
this
right.
administrative work.
That's right. Yeah, it's not the nature of the work itself. I mean, and one of the things I really like about Eleos, and I like generative AI in the space. The whole point of it is to get the junk off the desk, let you do what only you can do, and focus on those things. I do think I am intrigued by this non-ambient listening improvement process. I mean, do you think it's just an efficiency thing that they learn how to use that tool faster, better, easier, or something? Or what do you think
Yeah, I
caused?
do. Yeah. Like, if you've spent time looking at, like, the actual notes that therapists are producing and case managers and the like over time, the notes themselves, like, this is the pre AI notes, got pretty sort of formulaic, is what I would say. We have a lot of requirements. Some of them are from external organizations saying you have to hit these. Some of are internal around both quality and risk management. And you add enough requirements in there and you stop getting, like, interesting content, right? Because the work is, like, making sure you tick all these boxes. There were standard phrases people used all the time. There were
Yep.
standard things. And I think, like, a generative AI tool helps people cover those bases more rapidly.
It's almost like a cognitive cut and paste.
Yeah.
The phrases and stuff are sitting up here, and when you've got to get all this requirements, you just block the chunks of
Well,
text in.
and it takes some practice. Like, so dictation is another example of, like, it is not actually easy to dictate a session. But, like, if you dictate all your sessions all the time, you get good at it and you can do it quickly. But with the quick note, that's where we saw, the learning where, like, there was the initial pace and then, folks got 40% faster once they'd been using it for, 6 to 9 months.
Yep. What percentage of your staff that you expected to use an AI tool are not using it? Do you have an estimate?
Yeah, so we have not mandated the use of an AI tool. So I would say we've got about half of our outpatient staff using it right now. I would say like our psychiatrists and nurse practitioners have like a different note with different formatting. With any of this sort of technology stuff, I think there's this complicated thing of like you're actually delivering a whole solution, right? You have a fairly complicated stack. Like in a telehealth session, you've got like their telehealth platform, and you maybe have this sort of AI tool for documentation, and then you've got your electronic health record, which ties, the medical record portion ties into the practice management and billing portion, and it all needs to work together, right? And thinking like, well, do we just make the ambient listening tool map onto what we have, or do we change what we have now that we have this tool so that the format maybe is a little less structured, but could, because you can count on the tool helping clinicians cover their bases more completely, and yet you have sort of a richer, more interesting narrative.
Yeah. I think that idea, when we talk to new users of, Helios, they're they most of them are of your camp that we're not gonna mandate this. This is a tool to help people. But then over time, when you see the results, you know, what what I've heard, and I actually like this idea, it's like rather than mandating it, saying, "We now know that there is a way to get your notes done in 4 minutes. If you can get your notes done in 4 minutes manually, you're you're golden. But if you
Mhm.
refuse to use a tool that can expedite that, that's really not acceptable anymore because we now know it's possible. It's like evidence-based treatments. This is a kind of a maturity problem of implementation of AI. The initial one is who gets to try it and use it,
Mhm.
but once you're kind of well integrated, now you've got this new problem of okay, now I got
Yeah.
my curmudgeons who refuse to use it for some reason, and how do we handle that?
Well, and I think part of what you're talking about here is like trust, right? And part of it is change fatigue, right? And so we have a lot of change going on. And so some people are like, I want to stick with the devil I know, right? And the process that I've honed. The other part though is like, I don't trust AI. And what do we do? And I think in my seat as the CIO, it becomes challenging. And one of the things I really appreciate about like the Eleos solution in particular is that it, I think, was engineered for trust. So a lot of these ambient listening solutions, part of that involves a recording, and part of a recording involves permission. And I remember talking to the Eleos chief technology officer uh, about this, and he was like, "No, no, we rebuilt it. We rebuilt the solution so that it doesn't, if you use this particular form of it, it doesn't make a recording. Instead, it just listens for 10 seconds and then codes it. Like, so it skips the recording, skips the transcription, and jumps straight to the coding and the metadata, right? And so you're 20 seconds in and you've got two pieces of metadata and no recording, right? And I think that's really key for trust, like to be able to explain to people, like, there's no recording here. This is how this thing works. That was really key because it changed our rollout plan to just like, we're just going to mention we're doing it. We have not seen much in terms of folks saying, like, "I'm not comfortable with this being used."
Yeah. We see in general 2 to 3%,
Yeah.
which is kind of what I would have expected, especially if you present it well and
Mhm.
understand. And I agree with your. So where did you guys land on? scribe is the version that does not record anything. And you said inform people of it. Does that built in into your just basic consent when people come into treatment that you include that as a matter of course?
Yeah, yeah, and for solutions that do make a recording, we are making a note, a verbal consent
Yeah, yeah.
in the record, like, here's a cut and paste phrase to add in, but for solutions like Eleos' Scribe that don't make a recording, we're not even mentioning it.
Yeah. And what we know is too is that there are times like clients will be fine with it, but then one session they'll say, "Hey, let's don't use that today." And that's where the non-ambient, just write the
Mhm.
quick notes gives you the fallback and still take advantage of the AI without anything listening at all to the session. So I think that's encouraging about the way you're using this, I think. And so, yeah, okay, now I'm gonna jump back to kinda your professional journey and 'cause, I'm sure you might get touched or get asked about this, and I do as well. Is like somebody who approaches me, active clinician says, "Hey, I'd like to move into the IT space or the technology space somehow." What advice do you have for them, Wes?
Good question, yeah. Welcome is my advice, like, come on in, like, there's plenty of work to be done. I think the trick of the job, cultivating a list of problems. Like, these are the things we're trying to solve. These are the things we're trying to make better. And then also keeping in mind, like, what are the solutions, right? I think it requires a little bit of creativity to match those things together. One of the risks that people can have is coming in sort of solution first. I got this tool. Seems great. Let's deploy it, right? And I think, like, I keep coming back to advice that I got from one of my fellow board members on Prime Health was fall in love with the problem, not the solution, right? Remember, like, what are you trying to solve and make sure the thing you're doing solves it rather than like, I got this platform, tell me what you want it to do. Especially for folks from the clinical side, you're going to come with a head start around understanding these problems, but don't get distracted by the solutions. Make sure what you're doing really solves for it.
So, Wes, where do you think this stuff's gonna go down the road? Where do you think this AI in healthcare is ultimately? I mean, it is changing so quickly, and it's having such a huge impact on all of healthcare. Prognosticate for a minute for us. What do
Yeah,
you
it's hard to predict, right? It could go really well, it could go really poorly, or it could get really boring, right? Like, I think, in the really well, like, it continues to provide gains in reducing administrative burden and helping sort of automate. Remember the school-based clinician I was talking about and keeping those 8 steps in order. That's the kind of thing that I think AI and automation can help with. Like, here are the 8 steps. I'm gonna present to you the step that you need to do right now, right? Like,
or I'm gonna
not
take
to
what you just said and turn it into the steps.
that's
You know,
right, yeah. Helping people adhere to sort of best practices and protocols. The part where I'm, like, a little concerned is what we have is these fantastic computer tools that are just, like, recreating paper bureaucracy, right? And we have AI tools generating paper notes and AI tools reading them, and it's like, are we sure we need them? Like, the notes at all? Like, what if you had AI for ambient listening, and you had AI for clinical summarization, and then you had AI for sort of payment and claims, like, do you do you need the note? Like, could you just generate the note on the fly when you needed it and for the purpose that you needed it? Like, but we're not doing that. We're not building that system. We're building this sort of fragmented piece, and it's like, it's just a lot of resources.
it's actually it's a paper metaphor. I mean, it really is. We're still doing paper metaphor.
Yeah.
Hey, we could go on for this forever. I mean, I think that whole topic of where it's going, we could do another whole podcast on. But I want to thank you, Wes. This has been really great having you today. It's always fun to talk to a fellow recovering clinician and who's into technology. And I also want to thank Brooke Andrus and Harrison Bach, our producers, for this podcast. And with that, we will call it a day. Thanks, Wes.
Thanks, Danny. Appreciate it.